Have you ever heard of amyloidosis? If not, you're not alone. It's a rare, often under-recognized disease, but one with growing importance in clinical practice. Hi, I'm Amanda, and in this video, we'll explore what amyloidosis is, how it affects the body, and why increased awareness and early diagnosis are essential. Let's begin. Amyloidosis is a systemic disorder, meaning it can impact multiple organ systems throughout the body. Commonly affected organs include the heart, nervous system, kidneys, liver, and digestive system. At its core, amyloidosis is a protein misfolding disease. Certain proteins lose their normal structure and instead form amyloid fibrils. These fibrils accumulate in tissues, leading to the disruption of organ function. But despite its potential severity, the condition remains significantly under-recognized worldwide. While diagnosis rates have been increasing steadily since 2007, thanks to improved medical technologies, true prevalence likely exceeds what's currently documented. The incidence of amyloidosis in sub-Saharan Africa ranges from 0.28 to 0.57% in autopsy series. Secondary AA amyloidosis is the most frequent, found in 42 to 66% of amyloidoses. Chronic infections, especially tuberculosis, are the main cause. AL amyloidosis is found in 21 to 34% of amyloidosis cases, half of them due to myeloma. Other types of amyloidosis seem rare, but are probably underdiagnosed. The clinical presentation in sub-Saharan Africa is similar to that in Western series. Further experimental and clinical studies will allow a better assessment of the characteristics of amyloidosis in sub-Saharan Africa. Although epidemiological data remain limited, estimates from the United Kingdom suggest that amyloidosis affects approximately 8 individuals per million per year. At any given time, around 6,000 people are believed to be living with the disease in the UK alone. Now let's take a closer look at one of the most impactful and under-recognized forms of amyloidosis, amyloid cardiomyopathy, or ACM. ACM, also referred to as cardiac amyloidosis, is an increasingly acknowledged contributor to heart failure. It occurs due to the extracellular deposition of misfolded proteins, most commonly immunoglobulin light chains, AL, or transthyretin, TTR proteins, within the cardiac tissue. In cardiac amyloidosis, amyloid fibrils infiltrate the myocardium, the muscular layer of the heart wall, leading to a condition called restrictive cardiomyopathy, where the heart becomes stiff and unable to fill properly with blood. The result? Diastolic dysfunction, which eventually progresses to full-blown heart failure. In addition, the conduction system of the heart can be affected, increasing the risk of arrhythmias, especially in older adults. When amyloid deposits are stained with Congo red and viewed under polarized light, they exhibit a unique apple-green birefringence, a signature feature used to confirm the diagnosis. This microscopic property remains a critical tool in pathology labs worldwide. Amyloidosis is classified based on the type of fibril protein involved. The naming convention always starts with the letter A for amyloid, followed by an abbreviation of the precursor protein. For example, AL for light chain, a TTR for transthyretin. While more than 30 proteins can form amyloid in humans, only 9 are known to cause cardiac disease. Let's walk through this comparative table summarizing the main types of amyloidosis that affect the heart. The table breaks down each type by the protein involved, whether or not it is hereditary, the frequency of cardiac involvement, median survival, and the most common extracardiac signs. Starting with AL amyloidosis, the protein involved here is the immunoglobulin light chain. It is not hereditary, and cardiac involvement is seen in about 70% of cases. Median survival is around 24 months, but if a patient presents with heart failure at diagnosis and does not receive treatment, survival drops to just 6 months. Common extracardiac features include nephropathy, proteinuria, autonomic dysfunction, polyneuropathy, macroglossia, spontaneous bruising, and liver involvement. Next is wild-type ATTR, or transthyretin amyloidosis. This form also involves the transthyretin protein, but without genetic mutation, so it is not hereditary. Cardiac involvement is seen in 100% of patients, making this a strongly cardiac predominant form. Median survival is approximately 57 months. Typical extracardiac signs include carpal tunnel syndrome, lumbar spinal stenosis, and occasionally a ruptured biceps tendon. Now let's look at hereditary ATTR. Again, the protein is transthyretin, but in this case it's due to a genetic mutation, so this form is hereditary. The extent of cardiac involvement ranges from 30% to 100%, depending on the specific mutation. For the VAL142 mutation, median survival is about 31 months. For non-VAL142 mutations, survival increases to around 69 months. Extracardiac features often include polyneuropathy, orthostatic hypertension, vitreous opacities, and gastrointestinal symptoms. Finally, we have AA amyloidosis. This is associated with the serum amyloid A protein and is also not hereditary. Cardiac involvement is rare, occurring in only about 5% of cases. Interestingly, it has the longest median survival of all listed types, 133 months. The most common extracardiac signs include renal impairment in up to 95% of cases, as well as proteinuria, hepatomegaly, and gastrointestinal issues. Let's explore the three primary types of amyloidosis that affect the heart, starting with the most prevalent: transthyretin amyloidosis, or ATTR. A TTR amyloidosis is caused by the misfolding of a protein called transthyretin, or TTR, which aggregates and deposits as amyloid in various tissues and organs. TTR is mostly made in the liver. Once released into the bloodstream, its role is to transport vitamin A and the hormone thyroxine around the body. In order to do so, 4 individual TTR proteins must be attached to each other to form a 4-unit complex before it can carry vitamin A or thyroxine. In ATTR amyloidosis, the 4-unit complex is made up in the normal way but is unstable and prone to breaking up. In some cases, this is a result of inheriting a mutation in the TTR gene, which gives rise to TTR proteins that don't fit well together. This is known as hereditary ATTR amyloidosis. In other cases, the individual TTR proteins become altered as we age, but what causes this to happen isn't known. This type is generally referred to as wild-type ATTR amyloidosis. Once apart, the TTR proteins have a tendency to misfold and aggregate to form fibrils which deposit as amyloid. TTR amyloid deposits are most commonly found in the heart, where they cause cardiomyopathy, and in the nervous system, where they cause neuropathy. Deposits can also be found in the digestive system and kidneys. As the amyloid builds up, it starts to disrupt the function of affected organs and cause symptoms. The second type is systemic light chain amyloidosis, or AL. Proteins are important molecules involved in almost every structure and function within our cells. They are made up of chains of smaller units called amino acids, which fold themselves into 3-dimensional structures. Folding allows the protein to work properly and interact with other molecules. In amyloidosis, proteins are made in the normal way, but when they are released from the cell, they open up again. These abnormally folded proteins collect together in long chains of fibrils. The deposits they form are called amyloid. Amyloid fibrils are difficult to break down, and as they accumulate, start to cause damage. Eventually, the buildup of amyloid fibrils stops the affected tissue from working properly. AL amyloidosis is caused by a bone marrow disorder. The bone marrow produces blood cells, including plasma cells, a type of white blood cell that forms part of the immune system. Plasma cells make antibodies to help fight infection. Each antibody is made up of 4 protein chains. 2 heavy chains and 2 light chains which attach to each other to form the complete antibody. In AL amyloidosis, the abnormal protein that builds up and causes problems is the antibody light chain, hence the name AL amyloidosis. Instead of attaching to heavy chains, the abnormal light chains open up and bind to other abnormal light chains to form amyloid fibrils. These gradually build up over time Amyloid light chain fibrils can occur almost anywhere in the body, but the organs most commonly affected include the kidneys, the heart, liver, spleen, nerves, and the digestive system. Finally, we have AA amyloidosis, caused by serum amyloid A protein fragments and linked to chronic inflammation. It rarely causes cardiac involvement. However, isolated atrial amyloidosis, formed by atrial natriuretic peptide, has been associated with atrial fibrillation and is present in over 90% of nonagenarians. So there you have it, the three major forms of amyloidosis that can impact the heart. 1. ATTR hereditary or wild type. 2. AL from misfolded light chains. 3. AA rare inflammation related. Each type has its own pathogenesis, diagnostic challenges, and distinct clinical course. In our following modules, we'll walk through the diagnostic algorithm and emerging treatments available for these life-altering conditions. So why is amyloidosis still so difficult to diagnose? One major reason is the non-specific nature of its symptoms, such as fatigue, weight loss, edema, or neuropathy, which are frequently misattributed to more common conditions like chronic kidney disease, heart failure, or even normal aging. These overlaps contribute to significant diagnostic delays, often extending for years. Despite notable advancements in non-invasive diagnostic methods, including bone scintigraphy and genetic testing, transthyretin amyloid cardiomyopathy, a TTR-CM, remains underdiagnosed. This is largely due to symptom overlap with diseases like hypertensive heart disease and limited access to specialized diagnostic tools and genetic screening services. However, there is reason for optimism. Increasing clinical awareness and ongoing innovation in diagnostic techniques are enabling healthcare professionals to better recognize the signs of amyloidosis, particularly ATTR amyloidosis, a subtype that has seen a marked rise in recognition in recent years. A major advancement in recent years has come from cardiac imaging. This has been particularly valuable in diagnosing cardiac amyloidosis, especially in patients with transthyretin amyloid cardiomyopathy, ATTR-CM. Thanks to improved imaging modalities like cardiac MRI and nuclear scintigraphy, clinicians can now better detect myocardial amyloid deposits, which were often missed in the past. In our next lesson, we'll take a focused dive into hereditary ATTR amyloidosis, a genetically driven form of the disease. You'll learn about TTR gene mutations, inheritance patterns, clinical phenotypes, and the profound impact of genetic testing on early diagnosis and family care. Whether you're a clinician, researcher, or healthcare learner, understanding the hereditary form is essential to addressing disparities and advancing patient-centered care.